my honor to introduce Lakshmi, our PGY3. She has, Lakshmi underwent an extensive ophthalmology training before starting residency here. She actually went to Jawaharlal Nehru Memorial Medical College in Raipur, India, and then she was an ophthalmology resident at Kasturba Medical College, Bangalore, as well as Mandir Eye Institute in Udaipur. She completed a short-term training in phaco and emulsification surgery at the PBMA's HV Desai Eye Hospital in Pune, and also a laser and diabetic retinopathy management in Arvind Eye Hospital in Madurai, India. She completed her internal medicine preliminary year here at Albert Einstein Medical Center and is going to be a chief next year here in her neurology. After her completion of neurology, she has accepted a neuro-ophthalmology fellowship at Stanford University.
Whoa!
Good morning, everybody. I'm glad I'm able to make it here. I was out sick last 2 days, but here I am, and we'll go through our interesting topic here. It's a very common thing that we see very frequently in our floors and our ER. So I'm going to start with a case. This is a 40-year-old female that I saw 2 years ago. Past medical history of idiopathic intracranial hypertension, left frontal cranial fossa. Arachnoid cyst that is post-shunting. This was when she was 20 years old, and a left eye blindness secondary to a childhood surgery, a traumatic surgery, because of which she lost her eye on that side when she was 5 years old. She also had a gastric bypass surgery a few years back for weight loss. She now presents because she has been already on maximal medical therapy, and she's still having progressive worsening of her right eye visual acuity, the only eye she has left now. She was a 20/20 and now she is 20/40. Would anybody guess what would be the next thing that you would like to do? She's already had a shunt. She's already on Diamox, Lasix, is maximal medical therapy. So I'll just go ahead with my topic. I was going to discuss about our small subset of patients, the medically refractive patients of idiopathic intracranial hypertension, and what's a good time to decide when to go for a dural venous sinus stent, or should we go repeat or revise the LP shunt or the LVP shunt that they had before. Dural venous sinus stenting was first introduced by Higgins in 2003, and that's the first time they did a right IJ access and went through, and it was very successful. No complications reported at the time. It's a very upcoming discussion that is going on currently. Some people do not like it. Some people are going for it. So there's been a lot of papers in the last 1 year, at least 5 papers in 2017 and 1 new paper in 2018. I did a meta-analysis on it, so today I'm going to discuss a few things.
Let's just back you away from that mic, okay? Let's get rid of this one altogether. Back that way. Okay.
Can anyone hear me?
Okay. A little in between.
Is this good? Yeah. Oh, that's okay. So today in this lecture, we're just going to go briefly through the clinical features of idiopathic intracranial hypertension. It used to be known as pseudotumor cerebri. It's hardly used as a term right now. It used to be called benign, but it's no longer benign, but it causes a lot of visual loss, and at least 25% of people end up being blind with this disease. We'll discuss the treatment options, the surgical options, the medical options, and the role of dural venous sinus stenting in the selected group of medically refractive patients. What's the criteria for dural venous sinus stenting? When should we think about this in our patients? And what's the major and the minor complications of this surgical option when we decide to go for this option? And also compare the different outcomes of the different surgical modalities that we already know of, meaning optic nerve sheath fenestration, CSF diversion procedures like LP and VP shunts, etc. So we all know that IIH is a syndrome of raised intracranial hypertension without any mass lesion in the body in the brain, or we don't know what the exact reason is behind this. Currently, we use the modified Dandy's criteria, which requires that the patient should have signs of raised ICP, including headache, nausea, vomiting, no localizing signs except the false localizing sign, the sixth nerve palsy, ending up in the diplopia. The patient should be awake, alert. We should have a normal CT or MRI findings without evidence of thrombosis, except the ones that we normally see in IIH, which I'll come across in a short while. The LP opening pressure should be greater than 25, and we should have a normal biochemical and cytological composition, meaning no infection or no signs of any other cytological abnormality in the CSF. And there should be no other explanation for the raised ICP, like there is no bleed, there is no mass, etc. This is a very important step for all of us, whether you're a neurologist or ear doctor, or whether you're an ophthalmologist or a primary care physician. Everybody should be able to identify this, because a lot of patients come to us with headaches at every walk of our life, in the clinic, in the ER. So grade 1 is when you have a C7 halo on the temporal gap. We should always see that the temporal side is this is always the temporal side, where you see that there is a bigger gap, because here comes the fovea, because there's all the nerve fibers come in an arcuate fashion. The lesser angle side is always a nasal side. So you can see that here you have a normal temporal disc margin, and there's mild temporal halo here. This is grade 2, where the halo becomes circumferential and the temporal margins are blurred out. We have grade 3 here. This is, well, all the margins are swollen up, and the vessels that are leaving the disc, that would be around here, they are starting to become more blurred out. This is grade 4, when the vessels on the disc itself are getting blurred out. And grade 5 is you already have all the vessels blurred out, and is obscuration of the vessel of the disc mark. This is optic atrophy. This is not the best picture to show this, because sometimes there can be gliosis, and it can give a very white look around the margin. Sometimes it can confuse people that they have active or a different grade, like 3 or 4 of papilledema. It's only when you examine on the ophthalmoscopy exam with a slit lamp on the 90D lens, you can really see the 3D effect of the raised disc. There's also been a lot of discussion about the cup-disc ratio. Recent studies show that if you have a smaller cup-disc ratio, they are more associated with the ones with papilledema than the ones without papilledema, but there has been no proven association between the two. Also, we have to remember that papilledema, by definition, is swelling of both the optic nerves and not just one, because the fact that you have increased ICP gives a bilateral effect, not just one eye. If you have just one eye, then you want to suspect something like a drusen or any other etiology like AION or something like that. This is something that we see very often, an MRI finding for IIH. You have a flattening of the posterior pole of the eye. You can sometimes find tortuosity of the optic nerve sheaths, empty sella turcica, which you see very often. And sometimes one of the most upcoming discussion that you can find a stenosis of one of the or both the transverse sinus stenosis. So coming to pathophysiology, what causes this disease? So we know that there's increased pressure inside the brain. So some of the working pathophysiological idea is that it can be contributed by obesity, because of the central adipose fat in your abdomen can cause increased pressure, and in your right atrium that can cause a back pressure in your brain that can cause increased ICP. There's been literature about cytokines, leptins, and vitamin A, etc., but it's not very certain, and they're not able to prove it, like how exactly it affects that. Also, one important factor we all know is the female gender, that normally if you see in the general population, it's 1 to 3% incidence of IIH in the general population out of 100,000. But if you check the female population, the incidence increases more to about 20 per 100,000. So we all know that increased ICP can be because of increased CSF production or decreased CSF drainage. This is a simple chart to just revise that our main CSF production comes from the choroid plexus epithelium and a little bit through the ependymal cells in the ventricular system. The drainage part usually happens through the subarachnoid space, but there has been new theories that they've been working on that it can also go through the nasal lymphatics and also to the perivascular efflux system, and they also call it the lymphatics. Quick review of the pharmacological agents and systemic conditions that we should be aware of. A lot of people are taking antibiotics, tetracycline, minocycline, rule it out in your history taking. Vitamin A derivatives like isotretinoin, they have been shown to decrease CSF absorption. Corticosteroids, OCPs, and obstructive sleep apnea. You can have like this episodic sleep apnea during your night, and they can cause vasodilation and contribute to the system. Obesity. This is a very important point because some papers have shown that if you have a weight loss of at least 6%, it causes a significant even reversal of the papilledema. 5 to 10% is what you would like to lose. 6% has been shown in a case report to have reverse the papilledema. Microthrombosis from thrombophilia. This is also another important point to remember because there are certain conditions like prothrombin C deficiency factor 5 Leiden. They can cause certain small thrombophilia, microthrombosis that can contribute to this. Now I want to discuss about dural venous sinus stenosis, which is a very upcoming topic. We're not sure what comes first, so this is a very brief graph. Say if you have a sinus stenosis, it can lead to venous outflow obstruction. That itself can lead to hypertension that causes CSF decreased absorption through the pressure valves at the arachnoid granulations and cause an increased ICP, and that can cause a compression of the very fragile, flexible venous sinuses, and that itself can lead to sinus stenosis. This is a simple, funny picture that they're still working on that we don't know which one came first. I changed it three. So we don't know which one came first, the egg or the chicken, but there has been some theories say, I'm going to just quickly show this picture. This is a case that was reported by Ahmed et al. In 2011, where they did an LP on this patient, LP shunt on this patient, and you can see the reversal here very nicely, where the arrow marks had the stenosis before and it's open in the next picture. So it supports that theory, but there have been cases where even after you do the lumbar puncture or the LP shunt, the pressure has been normalized and you still have a significant stenosis. So now I'll come back to the types of the transverse venous sinus stenosis that people have been coming up with. They can divide it into extrinsic or intrinsic. Extrinsic is one that would be more careful about during surgery, and I'll discuss why. They're normally long, smooth, gradually and narrowing tapered stenosis, and the intrinsic ones are the one that looks more like a focal filling defect, either due to an arachnoid granulation or a fibrous septa inside the veins. Extrinsic ones, they usually are associated with increased intracranial hypertension. They are more challenging surgically, but they do resolve with CSF drainage. And the intrinsic ones, they cause IIH completely by occluding the transverse sinuses. Here's an example of the extrinsic type, where you can see a long tapered extrinsic compression, a long narrowed segment shown by the arrows here. And here's an example of the intrinsic ones caused by an arachnoid granulations inside. So quickly coming to the management, we're all aware when we have a patient like that, we do the ophthalmology examination, we have our suspicions high, we refer them obviously to ophthalmology later, but before that we want to do an LP to find out what the opening pressure is. If it's more than 25, we get an MRI brain to rule out any other structural lesions. We don't want to miss anything important and name it IIH. Also, we would have a good background in the history by then. We would also want to check out the visual fields and the OCT. Here's a quick view. Here you can see the first one. You have a grade 3, and the black lines show the swelling. Here you can see the level. It's normally between these green lines, which should be more than 80 microns or more, but here it's about 200, which corresponds to this. Next. This is great too, and you can see that it has resolved a little bit the swelling. There's no field effect in this first two visual fields so far. This is the one that's resolved, and you can see that the swelling has come down to almost the green level. So it's resolved, but here it has caused a lot of axonal damage, and that's why it has an arcuate field effect here. Medical management, of course, we know that the best option to go for first is medical management as long as the patient is not losing the vision acutely, like say he's coming to 20/20 to 20/100 in a few days, and you would like to go for something more aggressive. Until then, you want to do weight loss with dietary measurements. Some people go to bariatric surgery. It's a big controversy about bariatric surgery. People like to do it in the beginning, but some people don't like the idea because sometimes you can end up with complications affecting the abdomen. You can have adhesions, and this can be a problem in the future if you want to go for a CSF diversion procedure. Carbonic anhydrase inhibitors, we know this is our go-to. Here are some of the common medications that we use. Acetazolamide, Bumex is not often used. Topamax and Manitol have been used, but they're not the first options, especially because of the cognitive side effects, and the effect is not that well known either. Corticosteroids, we should be very careful. Initially, they used to be used for fulminant IIH when the pain, headache, etc. is a lot, but it can cause a rebound, increase ICP, and that's why it's no longer used. Excuse me. Next, we're going to discuss about the surgical management. So when do we decide we want to do a surgery for this kind of patients? And who are those candidates? These are people who have fulminant presentation, like acute visual loss, like I just mentioned, very severe headaches, uncontrolled with medications, who have failed medical therapy, and patients with refractory headaches related to chronically elevated ICP. So now I'm going to go and discuss about patients who are medically refractive patients. What are the surgical options? First, as optic nerve sheath fenestration, I do want to note that this is not strictly restricted to medically refractive IIH patients, because if a patient comes in for the first time and has severe visual loss, you do want to save the vision. ONSF is done just one time and cannot be repeated again the same eye because you make the slit open there. If that fails, you can go for other options. The next options, the gold standard that we all know as the CSF diversion procedure, the LP shunt and the VP shunt surgeries. Subtemporal decompression used to be done, is hardly done right now. And the last option, which I'm going to go deeper into, is endovascular dural venous sinus stenting. It's a very upcoming topic. Like I said, a lot of people are discussing whether to do or not to do, because complication rates have been really low with this option, but I will mention the complication rate, and if I mention what the complication is, people would be a little bit hesitant, but it's been very low. So first of all, after you place a stent, there's something called a Starling light resistor. It was a physiologist, Frank Starling, who found the Frank Starling law of the heart. He made a device where he had a box, and it was a very collapsible vessel inside it, filled with fluid, and the whole box was filled with air. That is how he worked with total peripheral resistance of the body. So if the pressure is less, it will open up. Pressure is more, it will constrict. So this is like placing a stent inside a vessel like that. So if you remove that Starling light resistor, it will interrupt with the positive feedback, and hence it will lower the ICP by letting the CSF drain out, and helps in symptom improvement. That's a working theory for this. Like I said, this is an extrinsic pattern where it's because of increased ICP, and this is technically more difficult to cross. It can cause, it's more challenging because it has a very high potential for increased chances of bleeding complications. The interventionalists have been using self-expanding stents as well as balloon stents, but they would prefer a balloon stents. But so far, in all the studies that I've seen in the last few years, they've been using self-expanding stents, and they've been doing well so far. This is one of the big landmarks in this surgical option. This is Ahmed et al. He was the first one to have the biggest study, 52 patients. They started dual antiplatelets on this patient. A week before, they chose the dominant sinus, and both of them were narrowed. Both the transverse sinus were narrowed, and they used self-expanding or balloon expandable stents in both of them. They kept them in the ICU after this procedure was done, and they continued Plavix for at least 3 months and aspirin for at least 1 year. Their criteria was those who had a transverse sinus stenosis gradient of 8 mmHg, and the clinical symptoms and the other criteria were met by the patient. The exclusion criteria is if you had an irregular stenosis and was kind of suggested more of a thrombus transverse sinuses. They rule out those patients and did not take them. And in the results, most of the patients, almost 52 of them, had complete recovery. They were papillotumoral resolved, but at least 6 patients had relapse, that's headache, and they were restented. But most of them were cured, like almost 49 was cured of IIH symptoms. This is my own meta-analysis that I did for the last papers from 2003 to 2015, including 30 papers. It's one of the most comprehensive meta-analysis. I just submitted it last month. It's focused more on success rates, complications, and restenting rates of DVSs. And here, the indications were patients who were medically refractory patients and having progressive loss of vision or symptoms. They had an obstructive flow pattern, which meant either the isolated sigmoid sinus stenosis or bilateral transverse sinus or sigmoid sinus stenosis, etc. And of course, they had to have a pressure gradient of more than 8 mmHg. So I excluded one paper because I couldn't get it, but there were a total of 410 patients. Females were 88%, males 11%, and the follow-up time was 22.4 months. This needs a very optimal follow-up, because a lot of people are thought to be well controlled, but they can still go on to have progressive loss of vision, so they need a very optimal follow-up. The BMI was 39.9, and the CSF opening pressure mean was 34.8, and the pre-stent pressure gradient before putting the stent in was 20.4, and the post-stent pressure gradient was 2.8. Here, there were a lot of patients who had already failed prior surgeries, like 77 of them who failed prior surgeries. There was high technical success rate. It's 99.5. There was one procedure that was aborted because they thought there was a rupture and there was spilling of the contrast, but luckily it didn't happen. And there was one procedure they had a technical problem with the stent and they could not complete the procedure. So there were only 2 procedures, as far as I know, that they could not complete this procedure. The major complications were low. Some people did femoral and some did IJ. I would prefer the IJ access seems to have lower complication rates, just pseudoaneurysm, but we'll discuss more. Some people did some literature search on, and there's literature on the cost comparison. There's one paper by Ahmed et al. Again saying that CSF diversion and DBSs, there was no significant difference in those two cost-wise. Here's a very quick graph, I would say. You can see here that the minor complication is only 1.5 and the major complication is 3.4%. But if you look at it here, the major complication includes subdural hematoma, subarachnoid hemorrhage, and ICH. I would like to note that there is one patient who had ICH, subarachnoid, and subdural both. So the numbers might give a little different view, but this one patient had both of this. And there was one patient who had subarachnoid and subdural, and there was one patient who only had subdural. This was reported in different papers. So, 2 of them, the one who had this, and this, was reported in Ahmed et al. 2011, and the next one was reported in 2012. After that, I have not seen any major complications in any papers. The minor complications were very minor, I would say. There was retroperitoneal hemorrhage, was managed. All of this were managed conservatively. They didn't need to do any stents or any aggressive treatment with this. They all resolved on their own. There's only one, the neck hematoma, which was seen with an IJ axis. Some people like the IJX better because it's easier. You don't need to go longer observation. It's a problem when you have a bigger, thicker, shorter neck. That's one of the cases where you would not like to use the IJXS, but it takes less length of stay for observation. Next is the overall complication. So a total of 4.9% if you consider this. There's one thing to know that a lot of papers do write about headache, but it's I discussed with interventionalists. They say that it's very normal and it's not really a complication from the surgery, that most people do have it and gets resolved really quick. Here's the restenosis and in-stent thrombosis. There were 5 people of all this, like there were 46 people total who had this problem. Out of this, 5 of them had an in-stent thrombosis, and there were 41 people who had restenosis. I have shown it in the graph and divided it so you can make out that here, those people who had adjacent stenosis were about 25 patients. 61% looked like a big number, but it's only 25% patients out of it says 40. 13 patients had in-stent stenosis, and 3 patients had it in another location like a sigmoid, and 1 transverse was on the other side. This is the same group of people, the 41 patients who had the in-stent thrombosis. They had the repeat procedures, and you can see in the pie chart here, the people who had the adjacent stenosis were the max people who, it's the biggest component of this pie chart, 41% for adjacent stent placement. So route of access, like I said, femoral was done in 83%, and IJ was 17%. Of note, the first procedure that was done in 2003 was IJ access, and there was no complication with it. This as the complication just kind of split out. IJXs were 4.3%, 2 out of 46 patients, and they ended up with a neck hematoma, which was resolved conservatively. The rest of it was retroperitoneal hemorrhoids, femoral pseudoaneurysm, retroperitoneal hematoma, and femoral vein thrombosis that were all managed conservatively. This is all the papers that I looked into and the kind of stents they look into, and the most common stents were the self-expanding carotid stents, Boston Scientific, and they use the Cordis Precise and Wall stent. It is not FDA approved. There's a company in New York that's currently working on it, and they're working on trying to make FDA approved for sinus stenosis, but currently they're using the carotid stents. So this is another paper that I had in 2015. This was more deeper analysis into the different types of treatment. We had analyzed 1988 to 2014, and we excluded all the small papers. This was major papers. The ONSF group had 712 patients, CSF diversion patients had 435, and the DVSS had 136 patients at this time. If you see the clinical outcome, they have resolution of headache in 83%, in venous sinus stenting represented by the blue, papilledema in 98 patients, and visual changes 78%, which you can see compared to all the 3 groups has a better outcome. Of note, I would like to say that ONSF is less in headaches because these are not usually done for headaches. It's mostly for visual symptoms. So in the first group here, it's less because you don't really do it for headache. This is the major and minor complications compared to all the 3 options, DVSS, CSFT, and ONSF. You can still see that the complication rate is very low. This is just to elaborate if anyone's interested to see what kind of CSF complications they end up with. I have seen a lot of complications with the CSF diversion procedures and a lot of repeat procedures associated with this. So you can see here there's 7.8% major complications, which includes shunt infection, tonsillar herniation, subdural hematoma, etc. And minor complications including abdominal pain, radicular pain, shunt malposition, operative complication, low pressure headaches, CSF, leaks, etc. But if you combine all the other non-significant ones too, it can almost come up to 94%. The ONSF has lesser complications. These are very minor things, minor complications that can resolve with time very fast. And most of them do not end up with a big permanent, at least it's not like subdural or ICH. Here is a comparison of the CSF revision rates. So you can see that out of 435 patients here who went from the CSF diversion group, 154 had revisions. And this 154 patients had 428 revisions, which means it's a very huge number. One of them had to undergo, like 4 of them had to go a VP shunt, and 1 had ONSF. So, and the number of repeat and subsequent procedures in ONSF was only 14% and 10% in DVSs. And the mean follow-ups were normally, ONF was done for 21%, CSFD 41 months, and 22.9 in DVSs. This is a quick pie chart showing the reasons for the revision. Out of his shunt obstruction, 40% was the biggest component, why they had the revisions for this CSF division procedures. This is one paper, it's back way in 1997, but this is just to show the extent of revisions people did before. Like you can see here, this is 1, this is 2, and there was one patient who had at least 38 revisions, one patient who had 29 revisions, and one patient who had 10 revisions. Now coming back to our case we had discussed earlier, she went an angiography and she had a direct venography and the pressure measurements which confirmed left transverse sinus occlusion and a left focal stenosis in the right transverse sinus, which had an associated gradient of 8 millimeters HE. So we went ahead and placed a stent on that site after having a multidisciplinary review with neurology, neurosurgery, and IR. And they had a right IGA approach with this, and they had a placement of a right ICA. They had a right IGA approach with successful placement of the Scortus stent across the pressure gradient on the right side. Here is right after the stent placement. You can see that it's patent here, which was constricted before, and this is after 6 months. She had some headache come back at 7 months, and they had a repeat CT venography here again, which showed that the stent was patent. Another quick paper where this was done in MUSC, South Carolina, where they studied 43 patients. Here they had headache improvement in 69.2% and 30% visual field improvement. The stent patency was 81% with an 18.2% restenosis. There was no complications, major or minor, in this study. This is another paper that was recently published in Neurointerventional Surgery. Here they had a group A and group B. This was interesting because here they studied the OCT findings of patients who underwent oral Diamox. Both the groups had oral Diamox, but this group had dural venous sinus stenting, and this was only oral Diamox. And you can see the amount of time they treated them. This is almost 6 months, and this is almost 19 months. And initially they present with 210 millimeter thickness in the average retinal nerve fiber layer thickness, and this was almost about the same, but you can see that that resolved to 85 and this resolved to 95. But the treatment time was so long with the group B people. This was done by a group of neurology, neuro-ophthalmology, and IR people, and here they concluded that if you have endovascular stenting, you can still prefer this as an early option, which can shorten the duration of medical therapy for these patients. This was for efficacy, another paper done in Acton Neuro Chair. This was 41 patients. They showed that ONSF had a good improvement in vision, and CSF shunting had a good improvement in severe headache response, but DVSs had a good option in both vision and headaches with best complication profile and low relapse rate, but a longer follow-ups are needed with these patients. Bariatric surgery is still in controversy, but with this study, they came up with flowchart saying that DVSs is a good option, but first you would like to go down through this flowchart. You wanna, if you have an IIH patient already confirmed with the modified Dandy's criteria, you wanna go think about ONSF if the patient is having extensive fulminant visual loss. If not, if they're having headache as well as visual symptoms, think about DVSs or CSF. If they have a significant sinus stenosis, go for DVSs if there's a pressure gradient. If not, you can think about the standard CSF diversion or the LP shunt. This is provided these patients are already medically refractive. If not medically refractive, these are patients who are having very acute symptoms that cannot wait. So if you go for ONSF and that doesn't work out, you want to consider CSF diversion or venous sinus stenting. If the patient develops severe headache or other signs, not just the visual symptoms. If you decided to go for DVSs and you're still having symptoms, you might want to consider ONSF if there's more visual symptoms that's dominating, or CSF diversion procedures. The last option, those who went for CSF diversions, you can consider ONSF again if your visual symptoms are more, or if DVSs, if there's a significant stenosis again. But what happens if all the methods have ever failed and the BMI is more than 40, they want to consider bariatric surgery, but again, some people are still controversial about it, saying that some say it should be done, it can be done early, while some say that you can end up with complications with adhesions, and that can be a problem with the CSF diversion procedures in the future. So I'll leave with my conclusion that if we have such a patient, we would always approach our maximal medical management. We should try medications and weight loss. We can check an MRV, we always do, with and without contrast, and then see if there's any significant stenosis. Check if the patient has had any, failed his medications. And if there's also an obstructive flow pattern on the MRV, then we can go ahead, if there's a significant stenosis, we can try venography with direct pressure measurements across the stenosis. And if there's a difference of more than 8 mm between the pre and the post pressure, then we can consider a multidisciplinary review between neurology, neurosurgery, and IR, and we can consider stenting if the visual loss is not rapid or a main symptom. Thank you, and we'll all see you in the evening. And any questions?
Obesity and pseudo tumor. Is it causing? I'm sorry, obstructive sleep apnea, pseudo tumor. Is it causing the effect or just because they're both common?
I think one of the theory that I read is when you have OSA, it does contribute to that. They have different mechanisms. The obesity they said is more because of central obesity and causing the back pressure up and increased right atrial pressure and back pressure to the brain. The other one with the OSA, they give a vasodilatation theory that when you have these apneic events that can cause vasodilatation transiently, and that can over a long time contribute to the increased pressure inside the brain.
Any studies on inflammatory markers in pseudo tumor in the CSF? Because you said steroids have been used.
They used to use steroids before. That's what they wrote in the most recent paper, but they said they don't use it anymore because it causes a great rebound headache and they don't like using it. Markers, no. There was one study about echoporin 4 because it's one of the transport channels that usually helps with transport, but there has been no antibodies or anything so far determined with this etiology, with this disease. And they studied they were shown to have increased leptins in one study, but then they kind of used controls on age, BMI, and sex, and they saw that there was no significant results with that, so they kind of pushed it aside.
Question, how do you do the measure the venous pressure between these 2 points? Technically,
I think.
That's really easy. There's 2 ways to do it.
Oh, Dr. Betty is here.
Yeah,
Thank
sorry.
you. I didn't see you. Thank you for coming.
Yeah, sorry, I came a little late. So if you could get there, the venous sinuses are pretty big as far as vessels go in the brain, but they're actually very, very difficult to get catheters into. Through the sinuses, it's very tortuous, and they're not like arteries, which are stiffer and they hold their shape. It's like trying to